Hello, good morning, good afternoon, and good evening to all our speakers, shares, and our audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from the USA, Professor Walter Reghin. Professor Reghin is a board-certified neurosurgeon with expertise in complex intracranial surgeries. He is a professor of neurosurgery at the University of South Florida and clinical professor of neurosurgery at the George Washington University. He is vastly experienced in both open and endoscopic skull-based surgeries. His clinical interests are focused on skull-based tumors such as vestibular schwannomas, pituitary adenomas, complex trigeminal neuralgias, and other cerebrovascular diseases. He has authored several scholarly publications and has an international reputation as a passionate teacher in neurosurgery. He has recently published the video atlas of minimally invasive cranial surgery. He also serves as a reviewer for many high-impact journals, and his quest for teaching enables him to serve the underprivileged countries across the world such as Somalia and other African countries where he conducts operations and teaching courses. We are extremely grateful to him for accepting our invitation to be a speaker at our webinars, and today he will be talking about minimally invasive neurosurgery turns 30. The speaker for the second session of today is our very honorable guest from Brazil, Professor Mateus Reghin Neto. Professor Neto is the director of the ICNE or Instituto de Ciências Neurológicas de São Paulo and also the head of skull-based program at the Hospital do Servidor Público de Estado de São Paulo. He was a partner and assistant to the legendary neurosurgeon Professor Evandro de Oliveira for a period of 10 years. He has also done observership in neuro-oncology, skull-based surgery, cerebrovascular neurosurgery with world-renowned giants like Ugo Ture, Gazi Azargil, Professor Ari Chris, and Professor Albert Rotten. He is a member of the Brazilian Neurosurgical Society, ACNS, and North American Skull-Based Surgery and the International Rotten Society. We are extremely honored to have him today with us, and today he will be talking about lateral transcondylar approach. The chair for the first session of today is our honorable faculty from Japan, Professor Jun Muto. Professor Muto is an associate professor in the Department of Neurosurgery at the Fujita Health University. He graduated in neurosurgery from the Kyoto University School of Medicine, Tokyo, Japan. He is a vice director of the Fujita Health University Surgical Training Center. Has been on board for several committees of the WFNS, namely the skull-based, education, neuroanatomy, and global neurosurgery committees. He is an invited speaker for conferences and workshops all around the world, and he is also a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable faculty who is from India, Professor Sanjay Bihari. Professor Bihari is the director of the world-renowned institute, Sri Chitra Tirunali Institute of Medical Sciences and Technology, Trivandrum, India. He was a former professor and head of Department of Neurosurgery at the Sanjay Gandhi Postgraduate Institute, Lucknow, India. He is a great ambassador for neurosurgical education and who has mentored over hundreds of residents during his period in SGPGI. He is an invited faculty to various conferences and workshops around the world. He was a former editor of the new journal Neurology India. His academic contribution sums up in several articles in prestigious journals and book chapters. He has over 8,000 citations and over 60 articles only on craniovertebral junction, and we are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kata, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. With that introduction, I would like to hand over this online podium to our first chair, Professor Jun Muto.
Okay, thank you so much. I'm Jun Muto from Japan. So it's my honor to serve as the chair of the Professor Walter Reghin. We have a great speaker, Professor Walter Reghin, and panelists today. So we are looking forward to listening to Professor Walter Reghin's lecture about the keyhole surgery and wonderful subject. I'm sure it will be enlightening, and we will have a wonderful discussion after his lecture. We are always grateful to the ACNS and Yoko Kato for their leadership. So please, Professor Reghin, start.
Can everybody hear me okay? I'm assuming. Thank you for that introduction. Thank you for inviting me to join you again. It's good to be with you all. It's very interesting to talk about minimally invasive cranial surgery with the Brazilians, especially because the South Americans seem to be the most resistant to this idea of all the people that I usually talk to. So let's see whether we can do some more convincing today. This slide is about the beginning of the skull-based surgery. I kind of grew up just after this era, and I certainly took a lot of pictures with the great ones. But everybody knows that the birth of skull base surgery in the 1980s, the whole concept really was doing everything big. This was an operation of mine in the year 2001, and we were certainly taught to do things big. Big incision, big opening, FTOZ, one-piece FTOZ, take all the bone off so that the concept is not to retract the brain. And the results were good. And this is a 20-year follow-up on this particular patient, which is great. But this is a patient of mine with a slightly bigger tumor, almost identical in the same location in the 2000s. And now suddenly everything has become smaller. And this case I did it maybe 5-6 years ago, tiny little opening, mini teriono, and same result, hopefully also 20 years. So thank you for inviting me to talk about this topic. Here I am. I always use a slide of Hong Kong with you all because I need to identify myself as Asian. and here it is, a picture that I took recently back at home, if you will. And obviously the Transorbital Society had a meeting there last November. That was a great honor for Hong Kong. That's who I am. And by the way, talking about minimally invasive cranial surgery, here's the new textbook. It is on sale now, at least a pre-sale, and will be physically available on the 15th of April this month. So, keyhole surgery turns 30. The concept was really invented by pioneers such as Dr. Pernetsky and Dr. Teo and Dr. Fukushima and so on. And the whole concept is really very simple. It's to minimize the footprint of brain surgery, and so that it reaches maximum efficiency with the least iatrogenic traumatization. Now, the question is, what do you define as iatrogenic traumatization? And the key tenets here I'll read it for you very briefly. To reduce the skin incision, soft tissue dissection, craniotomy size, so that you can minimize that so-called iatrogenic traumatization. And the results are very, very good. And so this started getting adopted throughout the world. Within the last 30 years, lots of data has evolved. And here are now the so-called standard keyholes of the current time. The supraorbital, mini-terional, and retrosigmoid keyholes for both microscopic and endoscopic approaches. Now, the concept is very simple. The deeper you get with a small opening, the wider your opening is, and that's why the keyhole concept works. The theory is that by doing a small opening, the tissue is less traumatized, the healing is better, the hospital stay is shorter, and the patient has a better experience while keeping the results the same. The question is whether that's real, whether it is supported by data now that we've got 30 years of experience. And then still is a little bit of doubt, and that's why people still need to be convinced that this is a viable and useful and efficient and legitimate things to do to patients. Here are some of the data within the last 30 years, right? So the overall outcome, talking about aneurysms now, are compatible to recently published conventional approaches. Talking about tumor, the second one says it offers equal surgical possibilities with less morbidity, and so on and so forth. Now, notice comparable and equal. That is the concept of non-inferiority. It's not better. It's just non-inferior. Now, herein lies the problem. If keyholes are non-inferior, why would anybody voluntarily lessen the exposure and surgical freedom? Doesn't that lengthen the duration of procedure? Why would anybody do, if it's non-inferior only, what is the proof that the short incision benefits the patient? What is this so-called iatrogenic traumatization? How do you define that? And for years and years and years, the people who did not like this idea, who thought that it was a bad thing to do for patients because it compromises the surgical freedom and lengthens the operation and makes it more dangerous, says that, well, you're only doing this because the size of the opening is inversely proportional to the surgeon's ego. So this is all about you. You surgeons want to show off that you can do things through small openings, and that's why you're doing this. It doesn't do anything for the patient at all. So that's the big reason why these techniques have been not universally adopted, not universally praised, and they're detractors. So we have to do something about this. The key thing for me was to show that this is not about the patient. It is not about the surgeon. It is not about the ego of the surgeon. It is really for the patient. It's better for recovery. In fact, it gets them back to work sooner, and it makes for a happier patient. Where's the data? Okay, so we have to find the data. So we finally conducted a study to address this as closely as we can, as scientifically as we can, and we generated a cohort study published in JNS. So we have a minimally invasive cohort, and we one-for-one handpicked matching cases in the classical cohort, and then we say, okay, here are paired groups, one-for-one pairing of various approaches, but matching for pathology, location, complexity, and so on and so forth. And then we can look at the patient data. And we already know that the outcome is compatible and the surgical complications are compatible. So we only looked at things that patients can feel. Patients don't know that they have tumor left or not tumor left. Patients don't know that their tumor is going to recur or not recur. Patients do know how long they stay in the hospital and how much pain they're in. So we looked at patient-centric data. And what that showed in this study was very interesting. Here, the matching and so on and so forth. The EBL is about the same. The duration of surgery is actually shorter in the Keyhole group, which was a little bit of a surprise. The length of stay was equal, but because the MIS group had complications included and classical group, handpicked to match, did not have complications included. If we took away the cases in MIS that had the complications, the stay becomes much shorter, significantly shorter on the MIS side. But here's the most important part. It's the narcotic use was significantly less in the Keyhole group. And that maybe is the biggest take-home lesson. And finally, we have some data that says that it benefits the patients and not about the ego of the surgeon. So hopefully this convinces more people that this is in fact a useful thing to do. So here are the standard keyholes. The first keyhole, the mini-terional, and certainly this is now the so-called workhorse, if you will, of minimally invasive keyhole surgery. It's very useful, something like this, a craniomeningioma. It gives you plenty of room through a very, very small opening, small skin incision, small bony opening, plenty of room for the anterior cranioidectomy. We're not going to belabor the point on the VR here. And here's the real operation. Everything's mapped out through augmented reality. We're not going to talk about that particular aspect today, but tiny incision. The planned opening is about 2 centimeters, no more than that. And as I said, the deeper you go from here, the wider the surgical field becomes, and so there's plenty of room to do the anterior cranioidectomy extradurally, safely. This is the peeling of the middle fossa dura, and then you will see that drilling the optic strut, as we usually do, that anterior cranioid has no trouble getting out of there, even through a very, very small opening. And certainly taking out a small meningioma like this is very, very nice for the patient, because finally we have data that proves this, that the pain is less, they go home faster, and it makes for a happier patient, which is the key of this. So here, final view of the tumor coming out, the optic nerve is decompressed, and so on and so forth. Everybody knows about this, so we're going to move on. And you can see that the incision is very, very small, and the patient was happy. The happier patient is the key to this whole thing. What about using this for aneurysms? I was certainly very scared of the idea initially. I was taught in the era where you had to prepare for rupture and everything big opening to make sure that you have flexibility to deal with that. But it turns out that if you use the virtual reality to plan this, a traditional terional opening is huge when it comes to what you actually need. Now, what are these little posts? One is the post of the projected direction or trajectory of the clip applier. The other post is the trajectory or planned trajectory of the dissection of the sylvian fissure. I looked at this thing and I thought, as long as my opening and encompasses these two poles. I don't need any of this stuff. So this is the one picture really that convinced me that I can do this through a mini-pterional opening. And having planned this through this virtual reality, I in fact discovered that it was in fact true. Whatever we planned was exactly the way we saw it in the operation. There's plenty of room to do this in a mini-pterional fashion without doing a traditional pterional craniotomy. So even for clipping complex and somewhat complex aneurysms, that you can see that I'm using an angle clip here. I have a dog ear. Suddenly I need to put in another angle clip. I still have enough room to manipulate. Simply have to use the left hand and the right hand, both hands, to put that. There's a dog ear. So you have a goalpost kind of configuration here. American football now, not international football. There are obviously cases where the mini-pterionals are not sufficient. I wouldn't use it to clip a complex aneurysm like this one. But again, for simple MCA aneurysms, the mini-pterional in fact has plenty of room to do so. And in fact, I'm more and more convinced of the keyhole for aneurysms. This is actually a previous rupture case, not an unruptured case, that we did on mission in Ethiopia 2 months ago. So this was done through again, so evolving from doing unruptured aneurysms now through small openings to now previously ruptured aneurysms through a supraorbital keyhole. Dr. Brunetsky's probably favorite keyhole, through a microscope, not an endoscope. We didn't have any endoscope in Ethiopia for mission. Again, as long as the dissection is fine, as long as you stay with the tenets of aneurysm surgery, everything was very safe and everything was successfully completed. And I'm more and more convinced that this is the way we can do aneurysms safely. There's no worry about doing it through small openings. So these are the first generation keyholes that I've already mentioned. Now, we're well into the second generation keyholes now. Let's talk a little bit about the supracerebellar infratentorial. The tiger triangle is what you go through to get to the pineal region through a keyhole in the retrosigmoid supracerebellar space, if you will. And 1 inch is plenty enough to do something like this. So I'm going to show you, this is a biopsied, the biopsy result from this was actually an intermediate grade pineal tumor. So we thought it needed to come out in this elderly gentleman. And we did it through a relatively small opening, again, about 1 inch, just paramedian. And this, of course, has to be done with an exoscope, endoscope, microscope, all the scopes available. So you can see here, this is an exoscopic view of the approach. And the exoscope in the sitting position saves the surgeon a lot of grief. So this is in a sitting position or semi-sitting position through the exoscope. Very comfortable. I don't need to stretch my arms. I don't need to kneel on the floor like that famous picture of Dr. Yazagil kneeling on the floor to do this, to be able to reach with the arms above. And so once you get to the third ventricle, the endoscope then goes in to get better visualization. You'll see the endoscopic view soon, I hope. We're well into the third now, taking the residual off of the top of this tumor. And once this is the endoscopic view. You can see all the way to the anterior commissure, lamina terminalis. And in fact, sometimes we fenestrate the lamina terminalis from this back end, so to get more CSF diversion. So again, plenty of room, small opening, second generation keyhole. And you have to believe me that this was fine, and let's move on. Now, what about the next generation, third generation, fourth generation keyholes? The question then becomes, what does the next 30 years look like for keyhole surgery? Now, Dr. Moore is a great friend of mine, and his brand of the next 30 years is going to look like one operation for the entire brain. In his own brand of genius, he can reach the posterior fossa with the mini-pterional or the minimally invasive posterior, the anterior lateral approach through the pterional route. I can't do that. He has the expert at doing that, and he's banking on one opening, the miplata opening, to reach almost all areas of the skull. And that could be one way that the next 30 years will go. Perfection of one particular approach from one particular direction. I have a different brand of this. I think of the next 30 years as designing and executing any which way possible to minimize the incision, soft tissue dissection, bone opening, and the collateral damage to the brain. And any way you can do so that fits these 4 criteria, well, that fits the tenets of minimally invasive surgery, and that's all you need. So it's not about one particular keyhole, 2 particular keyholes, 7 keyholes, whatever have you. It's about any opportunity you get to do things in a smaller fashion to take advantage of that and use technology, to leverage technology to make it safe to do so. And here's an example of such a kind of off-the-wall thinking. How are you going to do this through a keyhole, right? You have a falsi meningioma that attaches maybe to the bottom of the superior side of the sinus. Well, maybe it's not 1 keyhole, maybe 2 keyholes. So we did this biportal, and we rationalized that we have 1 small opening in the front, 1 small opening in the back, 1 small opening in the right, 1 small opening in the left, that you can get this, and then you can use the endoscope and all the visualization tools that you need. And so we did this through 2 keyhole biportal technique, but very, very small openings. And here's the plan in virtual reality. And here's the video. 2 1-inch openings, 1 from the front, 1 from the back. You debulk it from the front, debulk in the back, and now you're cutting the falx. And once you you secure your pericallosals, once you've debulked both front and back, then the endoscope goes in to examine the bottom of the falx. Here's the bottom edge of the falx, making sure that you have no tumor residual, and taking out all the tumor residuals that you can. You get the idea. But you have fulfilled the meeting of the 4 criteria of doing it through a minimal invasive technique. And this is how I think the next 30 years is going to go. Another example. Now, frontal sinus keyhole, everybody's used since the days of Dr. Jain, who pioneered this and wrote about this, doing olfactory group meningiomas. People have done transfrontal sinus surgery. However, the trick about this is not really about the bone opening, which is the focus of all these keyholes. It's really about the skin incision, right? Because if you had to still do a bicoronal skin incision, that always has this trouble with having the subgaleal effusion and people having this horrendously bulging head and discomfort. And this particular patient stayed in the hospital for a long time because of the discomfort of the bicoronal incision. Nothing to do with the operation itself, the bone work and the tumor work. It has to do with the incision. But the incision is as big a part of this minimally invasive idea as any other part of the operation. So we now doing this transfrontal sinus, true, Dr. Jain's technique, but through a gull wing incision. Just a tiny little incision there, but doing it with plastics technique. I always ask my plastic surgery colleagues to help us with this so that we make sure that the closure is done the best way possible and the healing process is done correctly as well post-surgery. And I think that has maybe changed the results for the better, that the healing of the skin and the scarring and whatnot have in fact improved with that. And so if you see this gentleman, especially if you have many wrinkles and whatnot, there is and if you have wrinkles, you're not going to see it much. Now, on a young person, it's debatable. So it's not about the bicoronal bone opening, no more of that, obviously, but also about the incision, not doing bicoronal incision, doing some small gull wing incision. How do you do a keyhole surgery of a foramen magnum? Well, again, just trying to use as much of the sticking with the tenants and try to do as much as possible to adhere to those 4 points that were erased. So here's something that we need to get to at the top of the near the aqueduct. How are you going to get there with a minimally invasive technique? All right. So here's all the bone that we're going to take off of the foramen magnum. Just a tiny bit more, an inch across, maybe slightly less than an inch. And then we take out a little bit of C1. And I think the key here is doing a stab incision around C7. We did a stab incision, put a pediatric chest tube in, and we did that all through the endoscope, through this opening through the chest tube from C7. And one surgeon is watching this go in very carefully at the foramen magnum, making sure that it doesn't touch the brainstem or harm it, and the other one's navigating the endoscope straight through the foramen magnum D up all the way to the aqueduct. So it's a two-surgeon, biportal, and I think the more important job actually is the surgeon watching this endoscope go in, making sure that the endoscope itself is not harming the brainstem. Because the driver of the endoscope is not going to see that. And here you go, at the top of the aqueduct, we take a little piece, and this turned out to be a low-grade ependymoma. It didn't need to be resected. And here's the endoscopic view. Again, the microscopic surgeon is making sure that the endoscopic surgeon is not tilting the scope to touch the brainstem and whatnot. A lot of attention recently has been on transorbital approaches, and certainly this is a great minimally invasive approach for lots of things, middle fossa especially. I have been using it for aneurysms, and this has been interestingly received around the world, and I'm grateful for the attention that it's getting. I think it is actually very well worth talking about and thinking about. The ACOM aneurysm. I figured that most of my exposure, the traditional exposure, is through the roof of the orbit anyway, because I always take off the roof of the orbit when I do this, following Dr. Zuccarello's paper many years ago. And I said, well, why can't we just do it through just the tiny little transpalpebral incision through the roof of the orbit alone without doing any traditional craniotomy? So again, planning out in virtual reality, looking at this thing 360, we said, okay, there's plenty of room to do it just through the orbit roof without doing a craniotomy. So here's the tiny little bit of bone that we removed. That's all the bone we're going to take off. That's the craniotomy. So the quote-unquote craniotomy is just the rim of the orbit. The top rim, this is the ledge of the orbit that overhangs the globe. And the rest of it really is taking off the roof of the orbit, as you see here, finding the optic foramen. And here we are finding the optic foramen, opening the dura then along the optic nerve, and then tracing the optic nerve from distal to proximal. If you go in that direction, obviously you will cross the A1 segment of the anterior cerebral artery, and the A1 will then take you to the aneurysm. We've done this repeatedly now with great exposure. Never had really any trouble with exposing the aneurysm safely and the temporary clips and all that. Here's A1. Here's the base of the aneurysm. We're dissecting the base of the aneurysm here, making sure the perforators are well visualized, and practicing placement of a temporary clip in case this ruptures intraoperatively, and then now dissecting the A2s. And there's where we're going to land the clip. And the clip goes in. Now you have to be ambidextrous because you have to sometimes use your left hand or the non-dominant hand. And as you can see, there's, with Dr. Mora's single-shafted aneurysm clip apply, there's no problems whatsoever with space. You always have to have plan B here. If it ruptures and you have to open to a much larger opening, you need to extend the incision quickly and have all that in your head planned out just in case you do have the rupture. Here's a dog ear. You can see the aneurysm has a little tiny little residual, so we're going to put in a tiny little booster clip there. And then here's the post-operative exposure, if you will. There's the opening that we actually use to clip the aneurysm. The white things are the two clips in the post-op CT angiogram. And so, again, it can be done with plenty of room this way. I think that this is appropriate for almost all anterior communicating artery aneurysms and not giant ones, with the exception of the ones that tilt backwards towards the perforators. Anything pointing up anteriorly, inferiorly, and inferior posteriorly, that's fine. But the posterior, straight posterior and posterior superior direction is the problematic one for this approach. Now, you can do this through the supraorbital, as we showed in the Ethiopian example. What's the difference between the supraorbital and the transorbital keyholes, if you will, if both incisions are identical. Well, maybe one is through the eyebrow, one is under the eyebrow. Big deal, the same length incision. I think it has to do with the trajectory of the aneurysm and the comfort of the surgeon with either approaches. I think that the transorbital is almost uniformly applicable because it makes you look upwards. The trajectory of the vision is upwards. The supraorbital one, I think there's a little bit more problems in looking up with that approach because it's a naturally downwards trajectory approach. So if you have an aneurysm that points straight up or up and anteriorly, it may be more visible, maybe easier, more visualized with the transorbital rather than the supraorbital. But again, it depends on your comfort. I think both are within the conversation. Both are minimally invasive techniques that we can use to improve our outcomes, our patient satisfaction, if you will, and so that we are in the conversation with the people who coil, and we still are within striking distance of, the coil results and so on, so that we don't become dinosaurs, if you will, in this particular disease entity. Now, so ACOM is that. Now, MCA is a totally different ball of wax. This will be either a mini terional, which you can do, but you can also do a transorbital for very selected patients. For very selected patients like this particular one, the transorbital, the lateral transorbital, is a very direct approach to something like this. I am not by no means saying that this approach can treat the majority of MCA aneurysms, but for the super selected ones that point anteriorly that are small in the sylvian fissure, this is a great approach, you can see. Now, this is a transorbital trajectory. We're opening the arachnoid anterior towards posteriorly in the sylvian fissure. We're dissecting the sylvian fissure here. You can see that the perforators are very well visualized looking from the transorbital route, which is very unique. Here's a big perforator, a lateral lenticular striate. Here's the aneurysm. And it's super short distance between the surgeon and the aneurysm. The aneurysm is pointing straight at me. All I need to do is dissect this tiny little vessel off of the dome of the aneurysm so that the clip can go on, be situated comfortably and across all of the neck. And you can see that it is a very direct and very short approach. And it's much easier through this transorbital route than the terional or a mini terional route because of the pointing of the aneurysm, the direction. So again, for super selected ones, this will be a great approach. This is a great approach. So what this brings up is that you're really tailoring the keyholes to the particular disease entity. If an MCA is pointing a very common way, you have to do it mini terional. If it's pointing a very unique way, which our study shows that about a third of the aneurysms in this location, MCA, can be approached through the transorbital. So it's not about whether it's appropriate for the whole disease, and it's about tailoring each keyhole to the disease entity and to the patient. And you can see the comparison this is the traditional terional opening, if you will, and look at how much smaller the opening is. And of course, the incision is about a third or a fourth the length as well. So here's your maxi opening, here's your minimally invasive opening. It's a big difference, and it does help the patient, as we have shown. Coming down to the end, we're using it for disease entities that you wouldn't otherwise think that a keyhole would be useful. This is a multiply embolized AV fistula, and we were called to action because of one last feeder that the onyx cannot reach. And we were asked to get to that particular point behind the area of skin that was compromised on the onyx. So we designed a way to do so. We know that there are 6 turns, so that's why the catheter can't get there. But once we get into here, we're okay. And this is right behind where the skin is compromised. So we have to be very precise. So the planning has to be very, very precise. But I think that a keyhole is perfectly fine. Now, you can use the microscope. You can use stereotactic navigation. The VR is just a little bit easier. What we did was we planned it out in VR. We kind of like marked out the segment of the artery that we want to get to, and we marked out the craniotomy that we want to make. None of this is, you can do this through stereotactic navigation if you want it, but here's a keyhole. We just need to get to that point of the remaining feeder, and use an endoscope to get to the fistula, and then the fistula's takedown is, as usual, the least dramatic portion of fistula surgery. Here's the endoscope going through that opening, that keyhole opening, and then taking down the fistula right there. This is about precision and planning, but again, it's about minimizing the dissection, the skin incision in every which way you can, to design new keyholes, to do custom keyholes, tailor-made keyholes, bespoke keyholes for these sort of disease entities, and they're even applicable for bypasses. This is Dr. Andre Truca's posterior cerebral artery, the occipital to posterior vertebral bypass, and you can do this through, his operation is designed to be minimally invasive, and then you can see this is not really a keyhole in terms of bone, but this is a keyhole in terms of skin incision and soft tissue dissection, and you take the advantage of where the occipital artery and the vertebral arteries are the closest to each other, and again, through a very small incision and least amount of soft tissue dissection you can, we drill out the vertebral artery from the transverse foramen of 2, bring that whole vertebral artery forward, well, more to the surface superficially, and then you put in the occipital artery into it. Again, trying to design a bespoke operation to fit the criteria or the tenets of minimally invasive surgery in benefits of the patient. And so I think that this is what minimally invasive means in the future, what the next 30 years of so-called keyhole surgery is going to look like. And you just have to remember that iatrogenic traumatization is not just the brain, not just to the skull. It's really about from the skin on downwards. And everything counts. Maybe the soft tissue counts as much as the most, or the skin may count as much as the brain. And because you don't want a patient with a big cone head or the big frontal bicoronal incision and having to stay in the hospital a long time. That would defeat the purpose of the minimally invasive concept. So I think the next 30 years is just refining all these various ways of doing it, and taking all advantage and all opportunities to minimize any which way you can the footprint of brain surgery. And again, I think the data from the JNS study has finally shown that it does benefit the patient. It is not just about my ego, and I think this is how the next 30 years will go. Now, why there is still objection to doing this, and again, I seem to have this discussion most with my South American friends. I think, except for Dr. Mura, I think that the idea still is that how do I transition? If I learned everything the traditional way, if I've been taught these big openings, how do I make the transition to keyhole surgery, and why would I want to do that? I think the why has been answered as much as we can through the patient data. I think the way to do it, the method to transition, will be to leverage technology as much as you can. So as you can see, I use virtual reality and augmented reality. Other people may use other techniques, other technologies. But I think technology may be the answer to that so-called difficult transition. Excuse me. So I'm going to stop sharing there. I would love to hear the panel's ideas and whether they think this is all crazy. I usually have a lot of people say that I'm crazy, and see whether we can explore any more of these ideas more thoroughly. Thank you very much for your time.
Yes, thank you very much for the showing the many keyhole technique and concept, Professor Reghin. So I completely agree with your concept of the minimum invasive. It's not a small. I completely agree with your idea of the minimum invasive. It's not only a small incision, not only a small craniotomy. So minimum invasive is a functional preservation and less brain in retraction, maximal nerve preservation, less complications. I completely agree with you. Yes. So may I have some question to you?
Please.
Okay. Yes. So about the minimum invasive clipping, for example, the transorbital ACOM clipping. So how do you control the proximal size? I mean, in trouble or yeah.
Yeah, the proximal side is actually very, very. It's actually maybe the most straightforward, direct part of the operation. It's because you start from the optic frame and tracing the optic nerve back to the A1. Your A1, by the time you reach it, is completely dissected from the start, which is at the carotid, all the way to the aneurysm. It's right in front of you. In fact, your A1 is in the middle of the field, the right smack middle of the field. So we have never had any trouble putting a proximal clip there. Now, if you start bleeding from a contralateral A1, that could be a problem, which is why I always say if you're going to do this, you have to have not only the right patient and the right aneurysm, the right sizes that you choose, but you also have to have the plan B ready. If it ruptures and you have a contralateral feeder, you can't reach, you have to, boom, because it becomes a conventional operation for ACOM within seconds, right? Incision, boom, open the bone larger. Within minutes, you should have a traditional opening. Hopefully that answers your question about proximal control.
Yeah, okay, I agree with you. So yeah, I understand that. So select the best approach and the best patient, and so preparation by a VR or augmented reality, right?
Yeah, I wouldn't do this even at this stage. I wouldn't do this for previously ruptured.
Yeah.
I would do unruptured only, and I would do anything from 7 millimeters to 10 millimeters. Bigger than 12 millimeters may become a problem, et cetera, et cether. So you have to be super selected, especially in the growing stage of evolution stage of this process.
Okay. And so these are the super expert technique. And how do you standardize this technique for younger or for educational point of view? Yeah.
Well, I think the younger ones are in the best position to really get to be experts, right? Because they're starting with it. By the way, all the residents who watch this eventually, you have to learn the traditional technique first. You do not go from small to big when you're learning. You go from big to small when you're learning. You go from the traditional opening, everything open for you to control. Then as you become more comfortable, you get smaller. You do not go from small immediately. That's number one. So the training has to be that way. The other way is just every time you do an operation for anything, at the end of the operation, always ask yourself, now, what part of this did I not use? What part of it did I open, cut open without using? Okay, maybe next time I can think about not opening that part. And then gradually, therefore, your operations get smaller and smaller and smaller and smaller and smaller. And I think that's the way that the field organically evolves towards less invasive technique. I hope that answers your question there.
Yeah. No, thank you. So I agree with you. And the last question is my interest. So I think that in the near future, so robotic technique is coming to the neurosurgical field. How do you think about this robotics into the neurosurgical neurosurgery?
All the work that we do, without the virtual reality and augmented reality, I don't think I would have made the transition. So I really depended on that technology to evolve my own skills and my own thinking. The VR and AR naturally evolves to the next step of robotics, because you're basically planning, every little step, every trajectory, every angle, and if you can then plan the robot's trajectory and angle. So I think it's absolutely coming, and the VR and AR are just preparations for that.
Okay, thank you for your comments. So, any other question to Professor Jin from panelist?
Suppose we can take comments from Prof. Sanjay sir.
Yeah, thank you so much. First of all, I'm really grateful to Professor Kano and Professor Kato. I mean, almost 30 years ago, they started a revolution in Asia, and we've all benefited from it. And Dr. Raja Kuti, I'm grateful to you for really taking it forwards. Professor Walter Jean, thank you for your comment, for your wonderful presentation. And Professor Jun Moto, I'm really grateful for your comments. I'd like to just comment on three different aspects of it. The first of it relates, I mean, we have had a discussion on this a little bit, but I mean, we have to actually very meticulously plan the minimally invasive approach. I mean, it is there. We cannot deny it, and we have to very meticulously plan it. Meaning, for example, I will just give you some landmarks. So, first of all, of course, is the key burr hole for the anterior area. But then, if you want to go a little posterior, then I think the root of the zygoma is very important, because the root of the zygoma actually directs you to the anterior petrosectomy and the anterior petrous apex. And anything which is posterior to that, you have to focus on the root of the zygoma. That's one. So the bone flap has to be very meticulously planned. The second important point is I would request Professor Walter to talk about the repair, because when you're going to the supraorbital approach, or if you're going to the transorbital approach, then there are ethmoidal air cells, and there is the frontal sinus, which is directly communicating with the nasal cavity. And if the dura is not really repaired properly, then there's going to be very recalcitrant CSF leak, or even recurrent meningitis, which may not be amenable to cure by an endoscope also, because right anteriorly in the frontal sinus, the endoscope will not actually cause CSF repair. So that is a very important point. How do you plan your repair along with the plan of exposure?
Great question. Thank you for that. So first of all, the transorbital clipping of ACOMs have caused me a lot of CSF leaks. So already you've hit the nail right on the head. I am beginning to think that a lumbar drain for 2 days is a reasonable thing to do for those. Not only for brain relaxation intraoperatively, but for the immediate post-op, meaning 24 to 48 hours use of that. Because there's no way you can close that dura. That's my alarm for talking too long. There is no way you can close the dura completely through that transorbital ACOM route. And so that dura is always going to be a little bit leaky. So, and whether the actual leaks through the skin, which is the transpalpebral incision, that's dependent on several things. But I think that intraoperative or postoperative lumbar drain is a interesting idea that I need to continue to think about, and maybe that will not compromise the length of stay if it's just used for a day and a half, 18 hours, 24, 48 hours. The other transorbital, the transfrontal sinus. The transfrontal sinus route has never given me any leaks. And the way I do it is to make sure I plug the nasofrontal ducts and lay the periorbital through the gallwing incision, small incision, harvest as much pericranium as possible and lay it down in preparation for that. So you basically cranialize the frontal sinus. So cross my fingers, I haven't had a leak with that yet. MCA aneurysms, that transorbital, is not a problem, and the other keyholes are not really a problem for leaks. But for sure, the ACOM one is something that's still in evolution. Thank you.
Yeah, thank you. So let me just take you approach by approach. I mean, just a very short discussion. So the second problem which comes up with supraorbital and transorbital approach is, the incision is almost on the forehead here, and so transorbital.
It's underneath the eyebrow,
or here.
Underneath the eyebrow. Underneath.
Yeah, underneath. But sometimes, what happens is there is a little bit of bone, defect here. And the skin of the forehead goes and it gets stuck onto the dura there, which causes later on a very significant cosmetic problem. Any thoughts on that? Have you had some patients? We've had this experience of having a groove come on the forehead over a period of time, although the patient improves significantly. So any thoughts on that and any ways?
Well, I think that would only be applicable really for the supraorbital keyhole, not really the transorbital keyhole, which is another argument for the transorbital keyhole, by the way. The supraorbital keyhole that you're describing may have that problem with the groove. What we commonly do is we use bone cement to fill that gap so that it doesn't sink, that doesn't become a mark there. Now, that's expensive, but I don't think the supraorbital keyhole is going away. Hopefully, the expense of the bone cement gets lower and lower as time evolves, and that solves the problem from start to finish. Okay. But again, so is it justified the expense of using that is the question.
Yeah. Thank you. Coming on to the mini pterional craniotomy that you talked about, what I have found is that when we're using a mini pterional, the Trans-Sylvian approach, definitely there is no compromise of that. But when we go to the subfrontal aspect of the pterional approach, which is also a very useful approach when we actually go to the anterior cranial fossa base, getting that corridor becomes a little difficult when you're retracting it. So, how do you actually ensure that you are getting both the Trans-Sylvian corridor as well as the subfrontal corridor?
Well, if you need a subfrontal corridor, you're going through the supraorbital. So you wouldn't be using a mini pterional if your main focus is the subfrontal. You go to the supraorbital.
No, but I'm talking about the mini pterional craniotomy that you sometimes use, the frontotemporal craniotomy that you use with an eyebrow incision. You don't use it at all?
No, the mini pterional is not through an eyebrow incision. The mini pterional is through a C-shaped incision behind the pterion.
Okay.
So it depends on where your focus of the operation is, where the target is. If it's mainly subfrontal, then you're using a different keyhole.
Yeah. So, but this has been a little bit of an issue because when you have a very small exposure, then it takes you to the pterional approach, the frontotemporal corridor, but the subfrontal exposure becomes a little bit of an issue, which sometimes becomes very useful, especially for an ACOM artery aneurysm. That's something which I thought was something we need to look at. The third was related to your posterior third ventricular approach. What do you do for, supposing you have a tumor which is on both sides of the straight sinus and on both sides of the falx? What we would do with a larger approach is we would go through the, to the interfalcine corridor to the contralateral side and sometimes cut the tent and go to the opposite side. That depends on where you are getting access. So you can both go above the tumor and you can go lateral to the tumor. So what is your approach for tumors which are kind of bilaterally situated and are kind of straddling the straight sinus from both the sides?
So you're talking about a falcotentorium meningioma?
No, or posterior third ventricular tumor. I mean, which is on both sides of the.
I think this is a very important concept for young people to understand, residents and whatnot. We can't just talk about things in the hypothetical, especially when it comes to these keyholes operations. They have to be tailor-made for the tumor. So the size of the tumor matters. The direction of the tumor matters. Where it reaches, where it does not reach matters. It changes the entire operation. So, when you say posterior third ventricular, it goes over this little area, I really can't answer that question until we have an actual tumor, a specific tumor, to design the operation. And that's the whole concept that I'm trying to get through to you all, is the concept of tailor-making the keyhole. It's not about using a generic keyhole for that tumor, this tumor, or whatnot. So it's about specifically design the keyhole for the specific tumor. So if a tumor is like that as you describe, and it reaches this way or that way or this way and up that way, it may be one keyhole. And then for another tumor that goes in another direction, another size, and then it's going to be a completely different keyhole from the top rather than the bottom. So that's the whole idea, is that you have to specifically design it. So I don't think it's I think it's counterproductive. Actually, the opposite side of what I'm trying to get over, which is, this, oh, I'm using this keyhole for this generic concept, right? It's everything is specifically designed. So specific tumor, specific design.
Thank you. Coming to the interhemispheric approach, when we're using, so sometimes you will have a venous lake or a vein which is connecting the superior sagittal sinus to a cortical vein, a major vein. And when we actually have a larger craniotomy, then we kind of factor that in, that we can go through two corridors, anterior or posterior to it. So do you have, you do a very meticulous 3D venogram or something to decide where you're
We do exactly that. When we do transcallosal work through a mini transcallosal opening, we have to know where the bridging veins are. So your CTV will have to tell you exactly where all those veins are, and then you design that keyhole specifically to be located in between the veins.
Okay, thank you. And of course, there are two, generic comments. One relates to, I think you'll agree with me that it has to be a very slow process and with adequate CSF drainage, because many of the youngsters will not realize that a very important component of the minimally invasive technique is adequate CSF drainage so that the brain becomes totally relaxed. That's one important point. And the second point relates to the fact that I'm working in an institute which is also focused on biomedical technology development. And I really think this is one area where, biomedical technology needs to be really developed for the minimally invasive approach. We are still using the instrumentation for our large, surgeries for our actual, for our minimally invasive. And that's why there's so much of problems coming up. So any thoughts on these things?
Absolutely. As you saw, all the aneurysm clip applies, all the bipolar is all single shafted. You have to have the right instrument for this sort of work. You can't use open surgery instruments for something like this. I would certainly not do anything transorbital with aneurysms if I don't have a single shafted clip apply. That's just absolute no-no.
Yeah, so I think as an end user now, we have to tell our youngsters to actually move backwards, and based on the degree of difficulty which they get in actual surgery, they can kind of modify their surgical instruments and ask the engineers to actually modify the surgical instruments to tailor to their operative needs. I think that the time has come for that. That will really make this minimally invasive concept very successful. So that's what my thought was. So have you had some contributions in that area, Professor?
Well, again, I'm on the shoulders of the giants that came before me. Right? The single shafted aneurysm clip applier was designed by Dr. Mora. The bipolar that I use are designed by Dr. Bernd Suter in Germany. All those are already available, and every year that we go by, we have more and more sophisticated tools. So on my personal, I have not been involved in that. The one area that could use some new tools is the semi-sitting pineal, because now we have the exoscope that makes it very, very feasible, but the instruments are a little bit odd because of the angle that your wrist had to take. My question moving forward for Mateus, actually, going into the trilateral, the trilateral approach, transcondylar approach, is the one approach I cannot figure out how to dissect, how to make a skin incision and the soft tissue dissection smaller. Dr. Spetzler has his ideas of doing a zigzag incision for that, but that operation is in need of a minimally invasive version on the skin and muscle. So with that, I'll turn over to the next speaker.
Thank you so much. Thank you. So Professor Raja, you could just take over. Thank you.
Thank you very much. All our questions were answered during these discussions. So now we do not have any further questions. We can take the final remarks from Professor Junmoto before we move on.
Well, thank you for excellent lecture, also comments, and to give us all the message. So we appreciate you. Thank you so much.
Thank you.
Thank you so much. So now it's time, before we move on, I would like to mention that this has been broadcasted on WeChat, YouTube and Zoom. Thanks to Professor Shubin, who does this meticulous work of broadcasting our webinars on the WeChat channel. We have a huge audience. So currently we are still waiting for his update. So we'll move on to the second session, and I'll hand this podium over to our chair, Professor Sanjay Bihari, to say a short introduction and invite Professor Reghin.
Yeah, thank you so much. I warmly welcome Professor Mateus from Brazil, who's talking about far lateral transcondylar approach. And I think I'm really looking forward to this presentation for various reasons. One of them is, the nomenclature itself is something which many people don't know about. I mean, what is far lateral, what is extreme lateral, what is I mean, so these are all when do you mobilize vertebral artery, when do you not mobilize vertebral artery, and these are important issues which need to come in. And of course, as has already been discussed, how to make the approach from maximally invasive to minimally invasive. And third very important aspect is how to use an endoscope to actually focus on anteriorly braced dural based lesions like a meningioma, and what are the limitations of those things. So I would request Professor Mateus to talk about the far lateral transcondylar approach. Professor Mateus.
Thank you so much for the invitation. It's an honor for me. Just my comments in Professor Walter Jean lecture. It was beautiful lecture, beautiful explanations. He said a lot about the South Americans. We are in a changing process. We discuss. Mura is a close friend of mine too. We still, for me, that I'm Professor de Oliveira School, I still think that in some cases that I need to move the microscope more. I need the light entering from different views. I need the instruments, the clip applied sometimes like this, sometimes like this. And I think the virtual reality, the augmented reality that Professor Walter showed us help us a lot to plan it. But I really appreciate your lecture, Professor Walter. Let me start with mine. I'll talk about lateral transcondylar approach. All my lectures, I start say thanks from my mentor, my master, my friend, Professor de Oliveira. This is when I start to work with him. I made a fellowship in his lab, and then he invited me to work with him. I stay almost 10 years together with him. He's the last time he entered in the OR just to help me with his knowledge. And he introduced me to my mentors, I said the giants, Professor Chris, Professor Almet, Professor Houghton, Yassajin, and Professor Ture. And my special thanks to Professor Christian, to all the team of the ANI that I'm continues my learning process a lot with them. I visit Professor Christian, Professor Almet few times every year to continue my process of my learning process. And I have a family that we giving courses all over the world with his ideas. Okay, I love this region, the foramen magnum region, the lateral approach, because it's all about anatomy. We have to understand a lot, to dissect a lot in laboratories to understand this 3D anatomy of the region, because when you understand the anatomy, you start to understand the anatomy of the disease. You have to understand if the tumor is here, how did they spread the nerves, what the tumor did to the vertebral artery. You have to understand where the pathology is growing and how displaced the normal anatomy. What we do in our surgeries is looking to is gain space to find our normal anatomy, our normal structures. The professor has a speech said the anatomy that you don't see, but we know that is there. You have to find in our space. I will show in my case some of them and looking for the normal anatomy. What is the definition of the lateral approach? The definition of a lateral approach is a lateral suboccipital or a retrosigmoid craniotomy. The size, Walter Jean, depends of the pathology. You can have a lateral approach with just inferior retrosigmoid craniotomy, or we can have a huge, depend of the pathology. Okay, but the lateral is this suboccipital lateral suboccipital retrosigmoid approach, together with resection at least of half of C1, and you have to deal with the condyle. This is We have this extreme lateral, far lateral. I like to call as all as far lateral and the variations of the far lateral, the transcondylar, supracondylar, paracondylar. I will discuss a little about this in my lecture, but this is the definition of far lateral approach. Okay, we sect at half of C1, we see the vertebral artery here, and here is the condyle, and we will deal with the condyle doing like as our previous presentations, minimal invasive. We drill as much as we need in each case. Okay, this is the Bible of this region, the article of Professor de Oliveira with Albert Horton. I have some publications about far lateral too. And we already understand the definition. And now we have to understand when we use a far lateral approach. I love this example of Spectre. You see this green. This when you are dealing with the midline suboccipital pathologies, fourth ventricle, everything, you do a suboccipital craniotomy. But when the lesion is anterior and lateral to the foramen magnum, when you need to come from this way, you know, this is Almaty words. You have to remove the bone to leave the brain alone. I cannot come from here and retract the brainstem. I would deal with this bone here to come this direction to go anterolateral to foramen magnum. And lateral approach is approach to deal with anterolateral pathologies of the foramen magnum around the lower cranial nerves, the vertebral artery, the pike artery. When we are dealing with this view, you need this view, this anterolateral view. You have to remove the condyle that's it was here, and you see the lower cranial nerves, the vertebral artery, the pica, the vertebral basilar junction will be deep here, and in this case we need to use a far lateral. Now I have the definition, have when we use the far lateral. Now I show my school the way we perform the far lateral approach and why. It's not the right way, but the way I believe professor teaching me and I'm desenvolving during the time this way. I love the semi-sitting position. You know, I love it because I have a lot of advantages. This is a beautiful picture of Professor de Oliveira and Professor Almaty discussing the position about this transcondylar approach. You know, me and Professor de Oliveira, we love the same sitting, and Professor Almaty always told us that we have to do in this lateral position that to have this kind of view. Okay, I'm discussing this a long time with him. The next case I will start to do in this position to see his ideas, because most of my case you see in this presentation is in semi-sitting position, and I love this kind of incision. It's a big incision, but I will show why I love this. First of all, we have to flex the head to open the condyle space. If the head is extended, this will be deep. You need to flex the head to open this space to enlarge this is our surgery. You do the surgery around here. Okay, don't flex too much because of the venous drainage. This is all we know. How we deal with the muscles? We deal with the muscles, the first layer in one plane, but we have to know the muscles that we have in this region. Okay, we have two layers of muscles in the posterolateral part of the head. The two layers is divided by the insertion of the muscles. We have this superior nuchal line. All the muscles that's attached to the superior nuchal line is the superficial layer, and all the muscles that are attached in the inferior nuchal line that's deep here is the inferior, the deep muscular layer. The superior have this one, the sternocleidomastoid, that is the only that I dissect here and put anteriorly, because it comes from down to up, from anterior to posterior. This, after the skin incision I will show to you, I dissect here and put it to the front. The other ones, this is trapezius, this is splenius capitis. You see all the superior nuchal line. This is splenius capitis. This is semispinalis. You see the difference of the direction of the fibers. This is splenius, this is semispinalis, a little deeper. Between both of them, splenius and semispinalis, we have a landmark that the occipital artery, we can find the occipital artery here, and here's the longissimum capits, okay, all attached to the superior nuchal line. This is the superficial layer, okay, this is posterior ventral of the gastric, and this is elevator of scapula. We'll talk then later. When I do my surgery, I perform surgery, I retract the sternocleidomastoid to the front, and all this together, I disinsert them, because deep of them, between the two layers, you have a fat plane, okay? And then we find this fat plane and put all down without a bloodless surgery. Look, this is midline incision, okay? I use hooks. You see how, if you know the anatomy, you can do a bloodless surgery with the all the planes. You see, I'm looking for the midline. Midline, a vascular incision. Okay, continue. In this edition, my fellow did not show the sternocleidomastoid to the front, but I retract the sternocleidomastoid to the front, and then all the muscles together down until I found the fat plane. When I found the fat plane, you see the deep layers are here. You see no blood because I'm doing, you see, straight now I'm seeing the deep layer. Okay, this is the deep layer. Let me continue. This is the deep layer. Okay, you see, just the deep layer we have to know is not attached to superior nuchal line, attached to inferior nuchal line. We have the hetocapitis posterior minor. Why is minor? Inferior nuchal line to C1, midline of C1. Okay, and you have the hetocapitis posterior major, that's in the inferior nuchal line, and the spinal process of C2. Sometimes it's tiny, sometimes it's large. Hetocapitis posterior minor, hetocapitis posterior major. Okay, then you have the inferior oblique from spinal process of C2 to transverse process of C1, and then the superior oblique or transverse process of C1 to inferior nuchal line. Okay, this makes us a so-called suboccipital triangle. Okay, the suboccipital triangle, hetocapitis posterior major, inferior oblique, superior oblique. Deep here, I know that's my vertebral artery is passing. Okay, sometimes the vertebral artery make a external loop. We have to see in preoperative exams, but this is our landmark to find another vertebral. Here is the posterior rams of the gastric, and the elevator of scapula should be here. Okay, this is an important landmark for us in this vision, that the transverse process of C1, because we have 4 muscles attached: superior oblique, inferior oblique, elevator of the scapula, you see, and deep here, deep to the posterior ventral of the gastric, there is a hetocapitis lateralis that is important when you are doing in the jugular region. Okay, here again a dissection that I made, suboccipital triangle. Okay, this is the way I do in surgery. Superior oblique laterally, inferior oblique medially. You see how I start to open my space here. Hetocapitis posterior major down, and then hetocapitis posterior minor I have to resect because I drill just 2 attachments: the insertion and the attachment, the insertion. Okay, the origin and the attachment. And now when you open the muscle, we can see the vertebral artery making this turn over C1. You can see the C1 anterior and posterior range roots, and we see the condyle. You see the joint of the condyle. This is where we need to work. Okay, this is a video, superior oblique. You see, the anatomy. You can cut the muscles, bloodless surgery. This is hetocapitis posterior major. I'm disinserting the muscles. In the final of the surgery, I reinsert. This sometimes nobody superior group, the superficial group, all I reinsert here. Okay, this is inferior oblique. You see how I can clean this region. Now, a step that is not always necessary, just a few times, but if you need, you can have the proximal control here of the vertebral artery between C2 and C1. Okay, this is the posterior root that I already cut, and this is the anterior root. You see, I have my proximal control here. If I need to drill to mobilize a lot, or the tumor is involving the artery here, I have my proximal control here. And this is head to capsule posterior minor that I'm taking it out. And then let me see again. This, I dissect the vertebral artery here. Okay. Let's continue. Okay. After we open the muscles, we start to deal with the region of the vertebral artery. It's very important for us to understand that you have the so-called Professor Kenan Almefti and Chris suboccipital cavernous sinus. There's a huge venous plexus in this region. If you don't need to mobilize the vertebral artery, if you don't need to drill the condyle, just field drilling, you don't need to enter it in this suboccipital cavernous sinus, but sometimes you need to. You know, here how I dissect. Let's see, this is my proximal control of the vertebral artery. I already showed to you. Okay, and now I start to dissect my vertebral artery. You see, I'm removing this soft tissue, and I start to see the condyle here. This is a really important landmark I will discuss with you in a few slides. There's the posterior condylar emissary vein. We have to know how to manage this. Okay, now I'm cleaning more because the condyle is deeply located on the vertebral artery. You see my vertebral artery here. I'm dissecting the posterior arch of C1 to can safely remove this, protecting the vertebral artery. I already removed. And now I like to prepare the foramen magnum with a caisson to make it easy to make the craniotomy. See, now I'm seeing the vertebral artery entering in the dura mater in the anterolateral region of the foramen magnum. Okay, now I perform my craniotomy. And after I perform my craniotomy, I have to deal with the condyle. This is the most interesting, important part of this craniotomy, because you have to understand the condyle, understand when I need to remove more or when I need to remove less. First of all, the condyle is situated in the anterolateral margin of the foramen magnum. Most of the people do a suboccipital craniotomy are drilling here and think they're drilling the condyle. No. See how the condyle is the anterior half of the foramen magnum. Sometimes foramen magnum is more rounded, sometimes more oval shaped, but the condyle is very anterior. Okay, and here is a craniotomy, it's a laboratory training with a huge craniotomy, but this is the specimen with the condyle, and this is the specimen without the condyle. For us to understand that if I need a more anterior view, I can leave this bone here and retract the brainstem. This is not the way we do, but we can remove this bone and go with our view straight anterior to the foramen magnum area. This is with the condyle and without the condyle. See how the corridor enlarge the corridor when we remove the condyle. It's similar when you have to work in the proximal Sylvian fissure or in the carotid system, and you don't remove the lesser sphenoid wing. You have bone there, you have to retract more. I think it's quite similar. Okay, and again, to deal with the condyle in this region, we have to understand that the plexus, the suboccipital cavernous sinus plexus, and most important of them is this vein, the posterior condylar emissary vein, because this vein is very frequently, we have a foramen here, okay, and what's important, that this vein goes straight to the jugular bulb, and sometimes it's bleed, and we used to put Surgicel deep, or sometimes glue, or sometimes bone walks deep. And if you put anything deep here, go straight to the jugular bulb, can give a thrombosis. And this is important for us to know and to know how to deal with. Another important landmark is the hypoglossal canal, because Even you do the famous transcondylar, I need to do all the condyle, not all the condyle. I need to make a big exposure of the condyle. We will drill until this. Do not drill deep of the hypoglossal canal. This is important because if you do it on one lateral until the hypoglossal canal, you don't unstabilize the craniocervical junction. You don't need to screw. If you drill until here, is the third posterior margin of the condyle. Okay, here is a video of the posterior condylar emissary vein canal. You know, foramen. You see, I put surgicel in the top of it. Don't put inside. And I'm dissecting and drilling with diamond tool just to see. You see the jugular bulb and how I drill and manage. Just put the surgicel in the top and then clean, drill it and coagulate it. Okay, this is important. And again, this is one landmark. The other one is the hypoglossal canal. We have to understand that the direction is posterior to anterior, medially to laterally, and a little up, down to up. Okay, here is laboratory training and surgery. This is C1, part of C1 joint, and this was the condyle that we drilled. Okay, how we know that we are arriving at the hypoglossal canal, because we have, when you are drilling the condyle, you have soft bone inside, and when you are approaching to the hypoglossal canal, you start to have hard bone again. Then you know that you are approaching, go slowly with a small diamond drill, and if you need, you open the hypoglossal canal. Remember, the hypoglossal canal, you continue in the top and in front of the hypoglossal canal, you still have condyle. Okay, and why not continue drilling? Because this part of the bone is the jugular tuberculum. And why it's important? Because just in the top of the jugular tuberculum, the lower cranial nerves make the turn to enter in the jugular foramen. Okay, here is a specimen that I remove the transverse, the jugular bulb, to see how the nerve passes in this region. You see, here you can see the 9 that enters in the top of the upper part of the jugular foramen. Here's 9, 10, 11. You see how the 11 branch make a turn. If you go drilling here, straight, is this dura is so thin, is easily you can damage and drill the nerves. Okay, here is the hypoglossal canal already open. If you need to do this variation that we call supracondylar variation, I will show in a video, Professor de Oliveira case, we have to do like a intradural clinoidectomy. This is a wrong name because the anterior clinoid process is extradural bone. If you do a intradural, it's not intradural. You open the dura and open the dura again to approach it extradurally. Same here. If you need to drill this, is not usual, is uncommon, but if you need to drill the jugular tuberculum, you have to open the dura, see the nerves, protect the nerves, and drill again. Open the dura again and drill. I will show in a case. Okay, let me show some examples just to see how we manage the condyle. First example, this is really small pica aneurysm in the origin of the pica. You know, it's a lateral. If the origin of the pica, you have to go anterolateral. You know, for this case, I didn't made in semi-sit, I didn't ventral position. I don't need, I know that I need to do just a little of the condyle, just remove this corner. I don't deal with the vertebral. I keep the vertebral or the plexus. You know, I drill a little, open the door, you see that I'm not happy. I still have some bone here. You see, then I put down the dura, drill again, you know, with the diamond, looking, everything. You see, I'm not happy. If it is continues here, I need to mobilize more the brain I don't like. I prefer to remove the bone. Then I remove this last part that I need, and now I have my straight corridor. You see, then I start to dissect. I found the pica, and after I found the pica, I just follow the pica retrogradely and go straight to the aneurysm. You see, I follow the pica and found my aneurysm here with the small space. It's a small space that I drew from the condyle that's supposed to be here. And I can safely dissect and clip it with no brain, just sustaining the cerebellum with no brain retraction. I like this this kind of clips that can enlarge your view in small space. And this is cleaning with just a small manipulation of the condyle. Okay, another case. This is a foramen magnum meningioma that we have to see the pathology looking for the normal anatomy. You see what I need to see here. How is the vertebral arteries? In the middle, 300 degrees of the tumor. You see, most of this tumor, if the tumor is soft, they make a hug, but sometimes you found a plane to dissect it. You know, this kind of surgery is nice to have a proximal control here if you need. Okay? And we know that the vertebral artery is the middle of the tumor, but there is a place that the vertebral artery is fixed. Is the place, the entrance of the dura mater, of the intradural segment. If I go there, if I dissect, I make a good approach, I go there, I will know where my vertebral arteries will be entering the dura. Okay, similar at the paraclinoidal carotid artery is a good place to find in those terms. And another thing that I am looking, I know that's in the middle of the tumor, is the hypoglossal canal. I go to my surgery looking for it. Again, I don't need, in this case, a big craniotomy. I made a lower craniotomy. I'm drilling around the condyle. I know the tumor is huge. The tumor, you give a space to me. I don't need to force a lot. You know, you see, I don't remove a lot. But now I see the medulla oblongata turned, the C1, the 11 nerve, and the tumor. And look how this is kind of minimal invasive to the brain because I have enough space. You know, the patient is semi-sitting. Most of the time, I don't need to use aspirator. I'm looking for the vertebral artery. I know the vertebral artery will enter here. But this tumor is a friendly tumor because they make a hug and I easily found the vertebral artery. And then I'm working aspiration the tumor. Look, you know, and enlarging the space that I have to preserve all the small branches. You know, my idea here is don't touch the brainstem and working in the middle of these corridors, preserving all the small branches. You see, it's a good tumor that comes in the ultrasonic aspiration, but this is whatever. And now I already found my vertebral artery, my pike. I'm looking for the hypoglossal nerve and hypoglossal canal because I know where is the canal. I know where I'm in the condyle and I know where to look it. I gain my space, aspiration the tumor, and then I go looking for the normal anatomy. Again, using Professor Christ's words of Michelangelo, I know I saw marble in the I saw angel in the marble, just carving it. I know the normal anatomy where it should be, and I'm working, looking to the normal anatomy. You see all the brains preserved, all the small branches. You see all the pica free, the vertebrates are in the middle of the tumor, but we have enough space with this approach. You know, it's not a small skin incision, Professor Jean. I don't know how to make this small because if you do in this way, open the muscles like this, you can use shortened instruments. You have more accuracy in your movements. You have more space, to mobilize. You see the vertebral basilar junction. I can see very anterolateral using the space that the tumor gave to me, and all the nerves is the jugular tuberculum, the hypoglossal canal, and jugular foramen. So, okay, this is a nice case because the tumor is friendly. We help, but the tumor help us a lot. The next case, I should just the patient well discharged and with the circle, the vertebral artery free, and everything. Okay, but this second case, this third case, is worst. Because the tumor goes very lateral until the contralateral, almost the contralateral jugular foramen, enlarge the artery the same. And go high. You see 7 and 8. This is a most difficult tumor. And in this case, I need to drill more the condyle. You see, but I'm looking for the vertebral artery. See, the vertebral artery is passing the lower part of the tumor. I know this already. Then I do the same. You see, in this case, the vertebral artery pass lower the tumor here in the top at the basilar stellar artery. In this case, you see how much I remove all this condyle. I want to make it flat like here because I need a lot of space to go. And you see, this is the condyle. You see the joint here. I clean, and make it very straightful. You see how anterolateral my view will gain. You see how I have this space to work. See the contralateral C2, contralateral 11, and now I'm start to see the same of the previous surgery. I'm cutting the ligament, the dentate ligament, to help me to mobilize the things. And now I'm looking for the vertebral artery in the lower part of the tumor. Now it's the same. I found my normal anatomy, I found my vertebral artery. Now I'm starting to find my spaces to work. And as I'm resecting the tumor, I'm looking for normal anatomy. I'm resecting the tumor and looking for my vertebral artery, for my lower cranial nerves, and all kind. You see this. I'm following my vertebral artery here. I just like this is a most hard tumor, most difficult than the previous one, but the same principle. Normal anatomy, big exposition. I can work comfortable, even I'm continuous dissecting and founding the nerves. You see, this is the jugular foramen. This is the 7 and 8. You see, jugular foramen 7 and 8, and I'm removing tumor, find normal anatomy, removing tumor, find normal anatomy, and continue until I see the basilar in the deep part, and I go a little fast until I can clean all of these lesions. And with the arachnoid plane preserved. Okay, again, I remove a lot of the condyle here, and you have a good resection of the lesion with this anterolateral approach. This case, my friend that asked me, is a really good case to put an endoscope. In the past times, we do not have endoscope. Now, in the new case, I'm doing endoscopic like view together with the tumor. Most of the time I resect, I put endoscope to see if there is any tumor left to see the corners, but I don't have any image here of the endoscope. This is a brainstem cavernoma. Is in the junction of the medulla oblongata and the pons, anterolateral. The point that it touched the surface is in very anterolateral. This is a really good case for a lateral approach. Again, in this case, I don't have a tumor to help me with the corridor. I drill a lot of the condyle. You see again, because I use this view to go from down to up. Here I'm removing the condyle a lot. You see the condyles here. I'm drilling. Sometimes use a Carrison, sometimes you can do continue drilling. I'm working more in the condyle because I need that space. You see there is still some bone in the corner here. I want to make it flat. I continue, and then when I open the dura, you see this is the space that I remove with my condyle, with the resection of the part of the condyle. And then it goes straight to our point. You see, this is the lower cranial nerves, the cranial brains of the hypoglossal nerve that's here. This is the 12 nerve in the preolivaris sulcus, 12 brains. This is, you see the yellow, the place where it's more superficial. You see the 6th nerve here. I already know. Then I go the most superficial part where the cavernoma is closest to the surface, and it goes straight to the lesion. And you see how I have space. This is I move the angle of the microscope. I have space to work with the instruments to make a very gentle resection of this cavernoma that are not so small. Gentle dissection, removing the cavernoma. We made a second look and remove that small piece that was here, and you see how remove the condyle that's here, helping me to this anterolateral view and postoperative with no damage to the brainstem or to the cerebellum. Okay, this is another case. This is a case of Professor de Oliveira. It's interesting because it's a cavernoma. It's quite at the same location, but in the other side. But in this case, similar approach of lateral, don't need to go too high to the craniotomy, is a lower surgery. But in this case, see what you are seeing. After you open the dura, we drill the condyle a lot. This is the vertebral artery. We drill the condyle a lot. But this bone here is the jugular tuberculum. It's so big in this case. You see, we need to see here. And this is in our view. And you see how the 11th nerve is passing so clean. Then he tried to find, you have to mobilize a lot, and still not happy with our space. This is Professor de Oliveira surgeon. And now he opened the dura again, like I said, the intradural cranioidectomy, and resect the jugular tubercle, and now go straight to the cavernoma. And now in the postoperative, you can see not only the condyle, but the jugular tubercle that is here that we dissect. In my last case, to show that we need another technique, is this lesion that all the pathologists, this lesion is growing. You see in the middle of the two vertebral arteries is growing. The patient is still well, oligosymptomatic, but the lesion is growing. You see? And they think it's a glioma. But I said, I'll go through it because if it's growing, we'll wait the patient stay in a bad conditions to go to surgeon. I prefer to go when she's still okay. But in this case, again, I resect a lot of the condyle to have my space. I need to go very anterior. But looking to the exam, I think this, I will see the olive. You know, I think the beginning, you see how I'm drilling a lot of the condyle in this case. I'm thinking the 12 roots will be anterior to the lesion. You see, I remove all the condyle, and when I see the lesion, you see, this is the lesion, this is the and the branch, the 12 branches are, let me return, are posterior to the lesion. This is the 12 branches. How can I approach the lesion from here? You see, this is the 11 nerve, this is the ganglionic mass, this is C1, you know, the posterior roots of C1. Okay, this is the vertebral artery, this is 9, 10, and 11. Okay, this is the 12 nerve going from here and passing here to enter in the hypoglossal canal. Okay, in this case, again, I cut the dentate ligament to can mobilize it more. And I said, how I can approach this lesion? The roots are anterior. Then I said, I need more space. It's not bone because the bone are removed, but I need to mobilize this vertebral artery. Okay, I mobilize this vertebral artery. I will cut around like the distal dural ring. I cut all around, and you need to a paraclonal aneurysm that you have to cut 300 degrees to can mobilize the carotid. Now I'm cutting 300 degrees the dura around the vertebral artery to enlarge my space. You see the anterior branch of C1, this is the ganglionic mass of C1 that will pass deep to the vertebral artery. But now I cut 300 degrees the vertebral artery and put a stitch, and now I go to the lesion. You see, I don't have bone obstructing my view, but I have this is the contralateral vertebral artery. And from my happiness, it's a cystic lesion with the beautiful dissected plane from the brainstem. And I can safely dissection using the space that I gain, mobilizing the vertebral artery. Okay, then you see, I put the vertebral artery down to up, but I mobilize it and can work in this corridor with a complete resection of the lesion and the brainstem return to his normal shape. Okay, more important than the post-operative MRI is the patient in good conditions, and you see. This is one of our questions, my friend, that to mobilize the vertebral artery. We used to talk a lot to mobilize in the foramen of C1, but this case is used more to deal with chordomas in this region. You know, when you move the vertebral artery extradurally, and now the patient in good position. This way, if you're doing with lesions intradurally, if you need to gain spaces, this kind of mobilization that you have in the patient in a very good shape after the surgery. Okay, this is my team, professor in memory of professor. We love surgery when done at superior level. For this, you have to study a lot in lab and see what our masters. Thank you.
So thank you, Professor Mateus, for the beautiful videos and for showing your approach, and going from simple approach to progressively more complex approaches. First of all, I'd like to just discuss the positioning of the patient. You operate in a sitting position most of the times. And but what I found was that when we operate in a dead lateral position without rotating the head, then the relative position between C1 and C2 does not change, and therefore it is very easy to localize the vertebral artery. What is your comment on that? And that way we can also actually see the brainstem tumor interface from a lateral aspect.
Lateral position, you said.
Yes, yeah, dead lateral.
Yeah, it's the same that Professor Matthew discussed with me, and I really agree. You know, like I do semi-sitting because we love like you can use a forceps in your left hand, don't need to aspirate it a lot, and we use like a small chair with roads that you can turn a lot. I'm sitting, I don't have these huge chairs, I don't use things here. I just fixing the head of the patient. I can turn my chair a lot and use like almost the same view, but I really agree that the lateral position, especially because I've been discussing this a lot with Tom Efti, and I have a case the next week, not the other one. I will doing lateral to start to see the difference, because I always say to Mateus, transcondylar you have to do lateral, but I love semi-sitting is my school, but I agree with you, and I will start to see, because
the point to emphasize is that there shouldn't be any rotation of the head. In retrosigmoid, we have a little rotation of the head, but in far lateral,
I never rotate the head.
because
I do semi-sitting, just flex a little, and I go lateral angles with my chair, but I don't turn because I like the anatomy of the vertebral artery. Perfect.
The second important point is, I think a lot of youngsters are confused about when you would use a far lateral approach and when you would use a transcondylar approach with vertebral artery mobilization. So what is your indication for, just because most of the people, we have had several debates on this, and everybody says there is no need to mobilize the vertebral artery. But those who mobilize the vertebral artery, like you and me, we really feel that we have continuous control over the vertebral artery. So what are your indications for just doing a far lateral approach? What are your indications for actually mobilizing vertebral artery?
Yeah, I think, first of all, I in my school don't say like it's two different approaches. Same approach with is a variation, is a enlarger of the approach.
Yes.
I first of all, when I do a mobilization in the arch of C1, the posterior arch, we open the canal, is more for extradural lesion like chordomas that you need to mobilize.
Yes.
Just when intradural lesions, I don't think this very proximal mobilization change a lot, but most of the time I go to see if I need, I return it, because if you dissect in 2 minutes, you can mobilize,
Yeah, absolutely.
But most of the time when the lesion is more like extradurally, I think in early stages to mobilize, but if it's not, no.
Okay. So, my indications for actually going more lateral would be, if the lesion is dural based and involves both vertebral arteries. Like you had the first case, you showed that the vertebral artery was involved, and if there is injury of the vertebral artery, then you can easily go anterior to the brainstem and actually put clips there. We've done it in a couple of cases. So that's one important. Recurrent lesion is another area where there is no good arachnoid plane, and that's where just going a little more lateral will be. And another very interesting thing which I noticed was, in large tumors you will always get space, but in a small tumor, dural based, very anterior to the cord, and that's where it's very important to actually go laterally, because the brainstem is not shifted. Yes, so brainstem is not shifted.
They vascularize the lesions, perfect.
This the another aspect of the whole thing is, I would divide this approach into two clearly different approaches. One is a higher lesion, which is at the level of brainstem, where you are actually doing a condylar drilling, and the second is at the C1, C2 level anteriorly, where we are working below that. So your thoughts on that, and what are the differences between the two? Something which is close to the brainstem and something which is at the atlantoaxial area.
Yeah, because the condyle is to higher lesions, the way you said. If C1, C2, don't need to. You do lateral drilling, but don't need to remove the condyle, because the condyle must to look up, to the brainstem. I think.
In a dead midline approach, would you approach from a non-dominant vertebral artery? Would you actually look at both vertebral arteries and actually work from the non-dominant vertebral artery?
It's if I think we have a important risk, yeah, for sure.
Yeah, so that's the other important point, which thank you for mentioning it in your anatomical point, that you have the paravertebral venous plexuses, which will cause significant bleeding sometimes. And there is another aspect to it, which is, the in a higher lesion, the sigmoid sinus and the jugular bulb will come just lateral to your approach. So, what
Mhm.
are your methods for dealing with this, continuous irritating bleeding, which goes on and on and on sometimes?
Yeah, I know. I use the Asterion like a landmark, and I
Mm.
never pass my. If I need to do a higher craniotomy, I can pass my drill over the transverse sinus, but the sigmoid I always do medially and dissect because of the breathing veins and drill. If I need, I drill with the diamond too and coagulate, but it's. I think we have to do the most safely as we can. You
Yeah,
know,
thank you.
for me, it's not important to be fast, and I do it slowly and safely, and
The
to
other
stay.
thing you beautifully demonstrated cutting of the denticulate ligament to actually get you more exposure. Many people neglect that approach because cutting of the denticulate ligament to actually give you more space between the brainstem and the anterior part is a very important. The first denticulate ligament, and
Yeah, yeah,
but when you're actually clipping your pica aneurysm, you are actually working distal to the aneurysm from distal to proximal, and you are not getting any proximal control. So there is a jugular tubercle in between, and you are working between the cranial nerves, lower cranial nerves. So what is
yeah,
your
yeah.
strategy for actually dealing with that? Which is, say, so for example, anterior medullary or lateral medullary pica aneurysm.
Yeah, let me see if I understand your question. No, this aneurysm is small, is a simple one. I don't. I feel very comfortable and don't dissect a lot to have my proximal control. But I know where it is. If I need to mobilize, if this aneurysm is rupturing, 20 seconds I have my proximal control there, but
Yes.
always for the people are learning, you have to gain your proximal control. This is like for me that I am a few years uh, uh, after my residence, I feel comfortable to go in that way, but for sure you have to always see your proximal control and stay in your hand.
Yeah, thank you. Coming to my last question, which was actually raised in the previous discussion, how would you actually make this approach more minimally invasive?
Yeah, this is a difficult, this is difficult because if you do, I saw all kind of incisions of this approach. Straight, the Z, the lazy S, and I like my way because it's huge incision in the skin for sure. But I make this deep structure so close to the surface. I can work so comfortable. If you do like a straight muscle cut and retract, at least you have to use the double size bipolar or scissors. That the way I'm using. This is what I
Uh,
think because you will stay so much more deep to the lesion, and then you are not so comfortable. I don't know. It's a good thinking. I don't know how to make this small, but it's still becoming comfortable. You see,
yes.
this is the
Yeah.
problem because you can do it small, but the important is to balance.
Yes.
It's
Absolutely.
minimal invasive in the skin in this case because it's so deep structure, but you still have time and different angles and use short instruments. I don't know how.
Yeah.
How do
It's, yeah.
Professor Walter will help? Walter
Now,
G.
now
help with me.
the how to come out, which means would you actually dissect layer by layer, or you would do the entire flap in a single layer, going up to the suboccipital triangle directly?
I go the first layer together, just
Okay.
the sternocleidomastoid to the front and all the first layer together down immediately.
Yeah.
And
Okay.
then the deep layers I dissect
So
layer by layer.
so that actually
Muscle
avoids
by
a lot
muscle.
of muscle atrophy in that area. Yeah, that's one important point.
Yeah,
And
yeah,
the
yeah.
other important point is when you actually cut the dura around the vertebral artery and mobilize the vertebral artery to do a condylar drilling, then how
Mhm.
do you actually repair the dura, or you just put a lot of fat there and put fibrin glue?
I repair as much as I can, for sure. Cannot tie the closure repair. The same as you do to
Yeah.
cavernous sinus, that you
Yeah.
sometimes you have to. I put stitches wherever I can and put fat and glue. This is
Okay.
the
Okay.
way. You know, this patient have a problem with CSF. This
Okay.
last case, I have a
Yeah.
problem with CSF. I have to return to the OR
Yeah.
to redo
And of
it
course, with
and put down lombard.
all brainstem lesions, you're doing a intraoperative monitoring, right? You would be doing that.
It's mandatory for us.
Yeah. Okay. Thank you so much. Thank you. Wonderful presentation. Thank you.
Thank you.
Thank you very much. It was indeed very nice and wonderful. One question that I would like to, if Professor Jun Muto is here, Prof. Muto, because of the peculiar some considerations in Japan, because the sitting position is banned by anesthetists in Japan. They never really allow a sitting position. So what do you
Yes.
do in your place to do a far lateral transcondylar approach?
Yeah, exactly. Thank you for a nice question. So in Japan, we are not we don't use semi-sitting or sitting position due to the complications. So we use park bench position and just rotation of the head. Just we use a lateral approach. Yeah, only this approach.
Right. Thank you very much. Any
In
questions?
Brazil, my friend, in Brazil we do semi-sitting a lot, but with a Doppler, transesophageal
Francis,
Doppler.
Yeah, I know.
And my anesthesiologist is my anesthesiologist that was trained by Professor de Oliveira. He was so good, and when he started the embolization, he said, "Is embolization?" He compressed the jugular, and we see where it's bleeding, and you know, I trust him, and he trusts me that I can control the bleeding. And we never had a huge problem. I have some small embolization, but never had a huge with damage to the patient. You know.
Okay. Well, great. So thank you very much. We'll come to the concluding part. So I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Walter Reghin and Professor Mateus Reghin, as well as the chairs, Professor Jun Muto and Professor Sanjay Bihari, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, that this has been broadcasted on WeChat, YouTube and Zoom, and as of now we have around 410 people live on all the three channels. So thank you very much. So until we all meet online again, it is bye bye from all of us.